Our fourth paper will be Puncturexis by Dr. Mohan Rajan. Can we have somebody call him? And can we now start? Yes? Which of you want to go first? Are you ready? Dr. Sheetal, are you ready? Not ready. Sir, are you ready? Dr. Biswas, are you ready? Huh? Yeah, na. Okay. Dr. Begur, are you ready? Chalo, let's start. So Dr. Megur is going to talk to us on multi-piece IOL in sulcus with optic capture or CTR in bag for eyes with weak zonules. Does it work? We'll try and maintain the same order that we've been given. So it will be Dr. Megur, Dr. Biswas, and then Dr.
This light off. I think it is not full screen, some resolution problem.
Presenting doctors to retain to the 6 minutes. Please start the stop clock again. And now this is going to be a tight race to the top. So we're going to have some questioning. We would invite also the audience to ask questions here.
Okay, respected judges. My paper is going to be on using the multi-piece IOL hydrophobic lens in sulcus and CTR in the bag for eyes with weak zonules. Can you play the movie, please? My mouse is not on. On the mouse. Yeah, I don't have any financial interest. And this, the traditional technique has always been that we use CTR in the bag and also lens in the bag for localized, the eyes with localized zonular weakness. This has been the standard technique which were there. But few concerns over for this technique is we have noticed that there has been long-term stability is an issue, late dislocation and decentration have been an issue, especially in eyes with pseudoexfoliation. So I propose a technique called as the IOL trap technique, wherein we have a CTR in the bag which produces the, can you remove this bar please, it's obstructing the view, which produces the equatorial support to the bag and a hydrophobic lens in the multi-piece lens. Remove the bar please. To analyze the outcomes, this is a prospective study involving 28 eyes who had got zonular weakness because of trauma or pseudoexfoliation. The important inclusion criteria here would be that the zonular dehiscence had to be localized, not more than 3 hours, and mild to moderate generalized zonular weakness secondary to pseudoexfoliation. The procedure which we used here was phacoemulsification and CTR in the bag and a multi-piece hydrophobic intraocular lens in the sulcus with optic capture. The outcome measures which were studied was IOL centration and bag stability over the late postoperative period. We took serial photographs of the slit lamp using retroillumination or diffuse method and compared them how they behaved over a period of time. This is one such patient who is having a localized area of zonular dehiscence secondary to trauma. We inject the CTR before phacoemulsification in this particular case after creating some space in the bag by using OVD. Then the phacoemulsification is performed. I'm placing the intraocular lens in the sulcus and aspirating out the OVD, which is both in front and behind the IOL, and then achieving the optic capture by tucking the, pushing the optic back, and we can see the ovalization of the rhexis is a clear-cut indicator of the successful optic capture which are achieved here. So this is how the patient eye looks during the follow-up period, and the rhexis continues to remain ovalized, and after 20 months the lens appears to be well-centered and stable. This is the next case wherein we are inserting the CTR after the cataract is removed, and once the OVD is removed, again I'm gently manipulating the hydrophobic multipiece lens into the sulcus and achieving an optic capture. Again, we look for this ovalization sign, and both the leaves of this capsule rhexis have to cover the optic, which is indicative of a successful optic capture. This is the final case wherein we are having this localized stabilization, but the important issue here is going to be how do we center the rhexis and size the rhexis, because these are going to be critical to achieve a good optic capture. In this case, I noticed that the rhexis is slightly bigger. In this situation, we need to manipulate the IOL in such a way that we at least get some area of optic, the anti-lens capsule cover over it, and we have an accurate optic capture as in seen in this clip here. So sizing of the rhexis and centration of the rhexis is going to be very critical. Among the 28 eyes, blunt trauma accounted for 20 eyes of the localized zonular dehiscence, and pseudoexfoliation, mild and zonular weakness account for 8 eyes. This is the demographic data which we have. The follow-up period was, the minimum follow-up period was 18 months, and the average was 24 months. And we took the photographs and studied them over a period of time. 26 eyes had excellent centration, 2 eyes minimal decentration, but did not have any impact on the visual outcome. This was because of an incomplete overlap. This is the photograph of one of our patients who the lens looks to be stable over a period of time. The limitation obviously would be that there is no control, but control is not possible in this. It's impractical because of the cases are of trauma. To conclude, the multipiece IOL in the sulcus with optic capture allows a primary benefit of better stability and centration. The secondary benefit which we have noticed is the pseudophacodonosis is significantly reduced compared to what we have in the back fixation. So apart from having a stability and centration of the lens, we also have this. The principle or philosophy basically is that the CTR in the bag is going to provide us with equatorial expansion and 360-degree support to the bag, and the hydrophobic multipiece IOL is going to be in the sulcus. The haptic in the sulcus and the optic being pushed back behind the capsular rhexis margin, it redistributes the weight around the capsular bag complex, and the haptics which are in front of the rhexis, they exert a sort of an anterior pull which balances out the posterior force extended by the weak zonules and the bag over a period of time. So we have a situation where the haptics in the sulcus are going to induce a minimal amount of anterior traction, which are going to balance out the posterior pull which is exerted by the weakening zonules over the period of time. And but two things are very critical here. The one thing probably is the right-sized rhexis and proper centration, and second is the the hydrophobic lens, because hydrophobic lens has the tackiness which ensures that the anterior capsule margin is glued to the optic. The glued rhexis margin to the optic along with an anteriorly placed haptic is going to balance out and prevent the late onset dislocation of these lenses. Thank you so much for attention. I have not used 3 types of lenses, sir. Only one lens I have used. That is a multi-piece hydrophobic lens. It's a single lens which we have used. There are no different lenses we have used.
In other types you would have definitely used a plain lens and a plain haptic lens.
This study is primarily to determine the long-term stability of using this particular type of lens in this group of patients. The group of patients include localized area of zonular weaknesses and generalized weakness because of pseudoexfoliation. This was a study prospectively designed to test just one type of lens, that was the multi-piece hydrophobic lens. which the haptics are anchored in the sulcus and the optic is pushed back in the rhexis margin. The equatorial support is provided by the CTR. Traditionally, we have been using both CTR and the lens in the bag. That has been the traditional technique which has served well for years. But few cases we have this late onset dislocation and decentration. That's an issue. So this is one criteria, but the important thing would be, you can't use it with other lenses. The hydrophobic lens is critical, and also it has to be multi-piece lens to be used in the sulcus.
My point was, when you're using this lens, you have already used those other lenses earlier.
Yes, ma'am.
Where was that comparison?
Those lenses we are all used in the bag, ma'am. Those all lenses were the single piece lens or the plate haptic lenses. We all traditionally put the ring and place the lens inside the bag. The problem with them is late onset decentration and dislocation. That is the main, and anticapsular fibrosis. That was the thing. But this is reduced. The incidence, of course, we don't have a control. I can't have a control because we don't have a trauma in the other eye. These are all traumatic eyes, or even the extent of zonular weakness cannot be have. So we can't have a standard technique in one eye and this thing. But in the period of follow-up, which I have had here for the last maybe 34 months, 24 months in the average follow-up period, the results have been very encouraging. It's still an ongoing study. Yeah, a few cases where vitreous had prolapse, subluxated cataract, traumatic cases. We did manage them with vitreous, and after managing all the vitreous, then we did this procedure. Place the ring in the bag and put the haptic in the sulcus with an optic capture in a 5mm rhexis.
Wonderful, sir. Beautiful thought. Very nice. Electropical lens. Thank you, sir.
I have a question. Can I ask a question, please?
Yes, I
Yeah.
wanted to ask, please.
It's a nice paper. I just have a question. The average time for dislocation we see in pseudo-exfoliation is 5 to 6 years.
Yes, sir.
So this study
Yeah,
average
it
was
is.
about
It is
20
still.
months.
I'm waiting for the
20
result.
months.
Yes, sir.
So over a period of time, you can have the whole bag can dislocate, and once you put the ring in the bag, that increases the weight of the bag. So this can cause some amount of decentration or tilt. Is there any way in your study where you are measuring tilt and decentration on a regular basis? Because even though the whole thing may not subluxate, once the zonules become weak and the whole bag starts tilting, then it can drag this lens.
Yes, sir.
The other thing is, why put a CTR at all? If you just make a can opening and put the lens in the sulcus, there is no problem.
No, sir. But equatorial support is critical because other the brag is going to shrink. You have got 3 areas of.
So if you make a can opening, a wide can opening, then you don't have a rim for it to contract and shrink.
Yeah, but when you have a can opener, we have all the problems with the can opener, like the lens never will be centered, even in the initial phases. Yeah, that it will be sulcus, but you will have all the problems which we expect with this thing.
Basically, you're putting it in the sulcus.
Yeah, I agree,
so
sir.
The sulcus is holding it. Not
Yeah,
the
I
bag.
agree, sir. I agree with that.
So
Yeah.
over a period of time, is there any way where you have checked the tilt? And
We are doing anti-segment OCT for all these patients. The primary concern is not about the tilt, but I'm worried about the PCO part because I'm expecting a space in between the posterior capsule and the back posterior surface of the lens. Unlike when you put it in the bag, these tackiness of the optic is going to attach the PC. I'm worried about the space which is there, which is more than what usual is. So we are doing an OCT, anti-segment OCT, to study that aspect of it. Until now, I have not gagged. And tilt, I'm not measure tilt using any of these devices.
I think tilt and decentration is very important.
Very
to measure
important.
because over a period of time, the bag can actually contract.
Yeah, yes,
and
sir. I
tilt
can.
with the CTR. That's what we
Yes.
see after 8 years, 10
Yes.
years.
Yes.
We get these dislocations with pseudo exfoliation. PCO is not a concern because at 3 months you have a shrink wrap effect. From 3 weeks it starts.
Yeah.
After 3 months it's complete.
Yes, sir.
So even if the lens is anterior, the whole bag is going to contract around the.
Yeah,
lens.
but the posterior capsule is not attaching it, sir. We have OCT done after 18 months also.
You see
We are seeing a gap in between the posterior surface of the lens and the haptic. But I have not compared it with all the multi-piece lenses in the bag also. So at this moment, I really cannot comment that how the normal lens is going to be behaving compared to this. But we are seeing definite space in between that thing.
Did you have any capsular distension syndrome? Because
No, nothing.
If you just do a capture,
Yeah.
then there is the LEC.
Yeah, but
basically
no, sir.
liquefy over a period of
Year
time,
at a time.
and you can get capsular back distension.
No,
We see
until
this
now, no surprises.
because
And
we typically see this in lenses which are placed a little more anteriorly.
anteriorly.
And if you have a good 360-degree
Yes, sir.
rhexis,
Yes,
which
sir.
opposes the anterior part of the lens, then
You have a
can
chance of-
liquefaction of the LECs.
Absolutely.
And you get, this liquid kind of
Yeah.
opalescence which is there behind the lens.
it is there.
Capsular distension syndrome.
Yeah.
So did you see that?
No, presently no, we are not.
That's also
And
a chance.
unusually no, nothing's there, but we are observing for that. But until now, nothing different from how a regular lens it behaves.
Okay, doctor.
That's it.
Okay.
So we get on to the next paper, and we have Dr. Biswas, and he's going to talk to us on the clinical outcomes of binocular implantation of trifocal intraocular lenses after cataract surgery.
Good evening, judges and ladies and gentlemen. I present to you clinical outcomes of binocular implantation of trifocal intraocular lens after cataract surgery. I present this paper on behalf of the presenting author, Dr. Sneha Batra, who is absent because of ill health. We have no financial interest to disclose. Cataract surgery is indeed becoming a refractive surgery these days, and with the advent of multifocals, it was supposed to be considered as a very good solution, and the different options were available. But with the multifocals, there are glare and halo, poor intermediate visual acuity, pupil dependence, and loss of contrast sensitivity, and that's how trifocal and why. The trifocal is a combination of diffractive structures in a single optic to provide specific foci, and convoluted diffractive steps to minimize dysphotopsia, and there is a less loss of light and thereby better contrast sensitivity. And therefore, the combination of the two bifocal diffractive structures give it the importance of having a distance vision correction, an intermediate, and a near vision correction. So the advantages of trifocal is a broad range of vision and from 33 centimeters to 100 centimeters. So we designed a retrospective study which was non-randomized, a duration of 15 months. It was informed consent was taken, 56 eyes of 28 consecutive patients at a tertiary level in an institute in Calcutta. The inclusion criteria was cataract patient with cataract in both the eyes, and we excluded any previous intraocular surgery and astigmatism greater than 1.75 diopters. Examination protocol was standard, visual acuity and contrast sensitivity, the intraocular pressure, the axial length, slit lamp examination, indirect ophthalmoscopy. The intermediate vision chart was taken for assessment of the intermediate vision, and thereby 67 centimeters, 80 centimeters, and 100 centimeters. And we also recorded unilaterally the vision. The smallest line was recorded and converted to logMAR values. The Pelly-Robson chart for contrast sensitivity was taken, and surgery was performed by one surgeon, and the intraocular lens was implanted in the bag. The visual acuity post-operatively was taken, contrast sensitivity was taken, and the quality of life questionnaire was circulated and assessed. Statistical analysis, a standard deviation was taken. The preoperative and the post-operative data were compared by the paired t-test, and SPSS software was 20 software was used for all calculations. The mean age of the patient at the time of surgery was 65 plus minus. 90% of eyes showed a spherical equivalent within plus minus 0.5 diopters at 6 months. All patients had binocular uncorrected distance of visual acuity 0.1 logMAR, binocular uncorrected intermediate of 0.1 logMAR 6 months after surgery. 85% showed patients achieved a binocular uncorrected visual acuity of 0.2 logMAR or better. The visual acuity comparison was statistically significant pre to post-op. Contrast sensitivity also showed a statistical significance. The results on patient satisfaction was very high, 96.43%. The visual outcome was confirmed by the percentage of spectacle independence. The Vergam et al., they had reported a spectacle independence of 100% for distance vision and for 80% for near vision with this particular intraocular lens. In our study, the spectacle independence achieved was 90% for eyes distance vision, 85% for near vision after a 6-month follow-up. So the Deveres et al. Study, the outcomes with the trifocal are good for distance and near vision, similar outcomes to a multifocal. Furthermore, the trifocal IOL enhancing the intermediate visual acuity. They also showed that 38.2% of patients were dissatisfied after implantation of a multifocal because they experienced major photic phenomena. On questionnaire, 96.43% was at least happy. So to conclude, the trifocal provides a visual acuity for distance, near and intermediate vision, good spectacle independence and minimal photic phenomena, and this gives rise to a very happy selfie vision. Thank you very much for your kind attention.
For your excellent presentation. What about the very notorious symptom of the patient of glare and halos? About
Glare halos. So in the questionnaire, the glare and halos were assessed, and most patients were asked direct question about glare and halos. In the, we had the questionnaire circulated to them in first month, 3 months, and 6 months. So in the first month, there was a certain percentage, approximately 20%, who said that yes, they were having a little bit of glare. This fell to around 5 to 10% in the second, in the third month, and 6 month, this was even less, approximately 5%. And we also, there was another part of the questionnaire in which did the glare prevent them from their day-to-day activities or night driving, was a direct question asked. So in again the first month, there was a percentage that said yes, but by the 6th month, they said no. I mean, even if they had reported glare, this did not contribute to a significant difficulty in driving night vision.
Means they have adapted neural adaptation.
Yes, neuroadaptation might
Thank you.
happen. Yes.
Thank you very much, Dr.
Thank you.
Biswas. Is there anybody else? Anybody who wants to have a question with Dr. Biswas? Yes, Dr. Ganesh.
I just had one question.
Yeah, Shukran.
In the contrast sensitivity, you showed that the contrast is improving over a period of time.
Yeah.
So normally with a multifocal, you get a reduction in the contrast.
Yeah.
And you should also put a normal range and see whether it's within the normal average range or whether it's outside the normal average range.
This is too small.
So was it outside the normal average range? That is one question. And the second is, why was a Pelli-Robson's chart used? Because basically the Pelli-Robson's is obsolete.
Yeah.
For studies, we usually use the FACT or the CSV 1000 for contrast
Yes,
sensitivity.
yes.
So that's
Actually, CSV 1000 we didn't have. We had the Pelli-Robson, so it was used in this study. The contrast sensitivity, that gradual increase of contrast sensitivity, we were also a little taken aback because we did not expect this to happen. But this is what you know, the graph showed. So I mean, we don't have an answer to
any
this. Why?
explanation as to why the contrast keeps improving.
Yeah,
And this is a hydrophilic lens, right?
It is a hydrophilic lens.
As PCO sets in, the contrast should reduce over a
Yeah,
period
but
of time.
again 6 months, so there was no PCO. In fact, we have been following most of these patients up for now about 3 years. So PCO, despite being a hydrophilic, is really minimal. So again, that is something of a revelation. Thank you very much.
Okay, Dr. Sheetal Bar.
Dr. Sheetal Brar is going to talk to us on the clinical outcomes of the new design of posterior chamber capsular fixation intraocular lens.
Good evening, respected judges and dear friends. I'm very glad to be here and be sharing 1-year clinical outcomes with a new design of posterior chamber intraocular lens with capsule fixation. Dr. Sri Ganesh is a consultant for Carl Zeiss Meditech. However, I do not have any financial disclosures to make. So we all know there have been various advancements in the field of modern cataract surgery. However, there are still many causes for patient dissatisfaction after a perfect cataract surgery. And these could be refractive surprises, IOL tilt, rotation, decentration, PCO, and dysphotopsia. So to tackle some of these problems, various capsule fixation IOLs have been investigated. We have the bag in the lens IOL from Walker, the Lentis laser lens from Oculentis, and the Masket ND-type 90S IOL from Walker. However, these lenses could not become very popular because of their potential limitations, such as removal of OVD from the bag behind the IOL may be difficult. Their designs are much complicated. They need special instruments and injectors for implantation, and they can have complications such as capsulotomy tears, capsular block, iris chafing, and pigment dispersion. So we present to you a new design of capsule fixation PC IOL, and to the best of our knowledge, this is the 4th of its own kind which is available in the world right now. It is not commercially available yet, but we have tried it in 25 eyes. So this lens is a single piece open loop hydrophilic acrylic IOL with a 6mm aspheric optic with a 360-degree square edge and an overall diameter of 13mm. So the speciality of this lens is that it has 2 extra haptics on the optic at 3 and 9 o'clock positions made of PMMA, which can swivel over a pivot. So this is a short animation showing how this lens is inserted. So first the lens is implanted with all the 4 haptics in the capsular bag, followed by which 2 Sinskey hooks are used to maneuver the swivel haptics on and capture it onto the capsulotomy on both the sides. This is the actual surgical video of implantation. So for this particular lens, you don't need any special injector or cartridge. Using the regular cartridge and injectors, you can implant this lens in the capsular bag with through a 2.8 millimeter incision. So first the whole IOL with all the 4 haptics is inserted in the bag, followed by which 2 Sinskey hooks are taken and used to gently maneuver the swivel haptic and rotate it on top of the capsulotomy. In the similar fashion, the second haptic is also captured on top of the capsulotomy. Following this, the position of the swivel haptics and the stability of the lens is checked. Irrigation aspiration is performed, and folds in the posterior capsules actually denote that most of the OVD has been evacuated from the bag. So the feasibility of implantation of this lens has been tried in manual phacoemulsification and femtolaser assisted cataract surgery. We obtained IRB approval and all surgeries were uneventful. IOLs of standard pass were implanted and the A constant of 118.4 was used. Mean follow-up is 1 year, however the longest follow-up now is 17 months. So regarding the spherical equivalent predictability at 1 year, we found that all the eyes were within plus minus 1.5 diopters of spherical equivalent, and the mean residual spherical equivalent was minus 1.12 diopters. So the best thing was that the anterior chamber depth did not change significantly at the end of 1 year. So there was no forward or backward movement of the lens, showing an excellent positional stability. Dilated clinical photography showed stable position of the IOL and swivel haptics, and no significant decentration or rotation was observed over time. We also studied the IOL tilt using the Pentacam Scheimpflug image system, and then we found that mean IOL tilt from 2 weeks to 1 year was within 1 degree in comparison to the IOL in the bag IOLs, where it can be as high as up to 10 degrees. We also studied the eye trace for internal abrasions, which were very low, indicating no tilt. Ultrasound biomicroscopy also showed a more anterior position of the lens, which could explain that none of our patients actually reported any positive or negative dysphotopsia. Regarding the PCO incidence, 2 eyes out of 25 eyes showed evidence of PCO at 1 year, and 1 eye underwent capsulotomy. So the potential advantages of the new capsule fixation IOL could be, it's a simple design. It can be implanted through a standard injector through 2.8 millimeter incision. You don't need any special instruments or surgical training, can be used for flax or manual phacoemulsification. Easy removal of OVD from behind the capsular bag is possible. It provides stable fixation and effective lens position, good centration with no or minimum lens tilt, and no pigment dispersion. So to conclude, the new capsulotomy fixation IOL was feasible, safe, and stable at the end of 1 year. We need more data to investigate long-term results and optimize A constants. And future research is already on to develop the IOL on a hydrophobic platform and also toric and multifocal platforms. Thank you for your attention.
Excellent presentation and very novel technique, Dr. Bra. And I just wanted to know that the third and fourth haptics which you placed into above the caps.
Yes,
capsule?
sir, above the
Anterior
capsule.
capsule.
Above the CCC, sir, on the.
Above the CCC.
Yes, sir.
No, it's inside the bag, no?
On the extra 2 haptics.
Anterior capsule.
That's a capsule.
Okay,
So that's why it's a
The
capsule
idea is
fixation.
to
IOL.
thus the
You have a
Close the
anterior
space.
capsular fixation. So you have 2 in the bag and 2 outside.
so
Very
this
nice.
So it doesn't, it's a boon for for toric IOLs because it won't rotate. There's no positional change over time. Even with the capsular contraction over time, we hardly see any tilt or decentration.
Would you say that we don't need a CTR then?
CTR, no. Because it's...
Do we or
See,
do we not need?
we don't recommend putting this lens in weak
In an eye
bags.
with a CTR. You don't want it in an eye with a CTR. Okay.
No, but for...
Can this lens help us avoid putting in or not need to put in a CTR?
It's not for a subluxated lens.
It's not
Okay.
for
It's
basically...
Basically to improve the effective lens position and then
Okay.
to prevent the lens from rotation.
Okay.
And you don't have negative dysphotopsia because we know that sulcus placed lenses don't have any negative dysphotopsia.
The
So
lens
it's only
is
the lenses in
forward.
the bag
Right.
which have, because the more posterior they are, you have those negative shadows.
Right.
And with this lens, you avoid that because though you have a patient where the surgery has gone on very well, they are unhappy because of the shadows and on the temporal field, and this lens avoids that.
Wonderful lens. Yes, Dr. Begur.
Sir, my concern would be regarding the PCO part because the contact between the posterior capsule and the lens is you're taken away because it's much more anterior. It's anchored to the anterior capsule. So again, we have an hydrophilic lens. Obviously, even if you come out with a hydrophobic variant, we are just shifting that whole contact area. The thickness of the lens is not going to change, right? It's going to be the same. So in that situation, PCO is going to be my biggest concern in this situation.
If you observe the UBM, you can see that the posterior capsule is in contact with the lens. Because what happens is, this is what I was explaining in your paper also, there's a shrink wrap
Can you
effect.
go
The whole
back?
capsule is lax.
Can you go back?
So it
Show my
shrinks
presentation.
around the lens. So whatever the position of the lens, as
gives
the
a very
bag
good
shrinks,
Shrink wrap effect.
it will shrink around the lens, and this lens has a 360-degree square edge.
Square edge also.
So that's why the PCO is
Can you
not
please
very
show?
high. We have had one patient, but then on a hydrophobic platform with a square edge, the PCO rate should be no different from an in-the-bag lens.
Thank you very much. Can we move on now to Dr. Mohan Rajan, who is going to give us a talk on puncturexis.
This is really a new technique that we have to evaluate later on.
Thank you. Chairpersons, ladies and gentlemen, white cataracts can be type 1 intermittent white cataracts or mature white cataracts or hypermature white cataracts type 3. The problem with these white cataracts is that as soon as they touch, there can be, because of the raised intralenticulaar pressure, the Argentina flag sign where the rexus can extend to the periphery and across the zonules into the PC as well. And this is one of the major problems which can occur with all these intermittent cataracts because of the increased pressure both in front, that is underneath the anterior capsule, as well as underneath the posterior capsule as well, or in front of the posterior capsule as well. So what is the problem of this Argentina flag sign? If you have an Argentina flag sign, it can produce a PC tear, or even you can extend across these zonules into the PC and produce a nucleus drop as well, which can be disastrous to the patient. So there are many ways of overcoming this Argentina flag sign. The 30-gauge needle, wherein you can introduce into the anterior compartment. The main problem with this particular technique is that it takes care of the pressure which is there only in the front compartment which is there and doesn't sing. So this can also be done with another thing with a 26-gauge needle as well, wherein you can decompress the front compartment. Or you can use a femto laser, which is very costly, or even a zepto laser, which is also less costly than femto laser, but which is not available to everybody. So what I'm developing a technique is this. See, if you see this animation, there is a pressure in front of the, underneath the anterior capsule. There's a pressure in front of the posterior capsule that is behind the lens, and the pressure in the anterior vitreous as well. And the nucleus is also bulky. As soon as it touches these capsules, what happens is the nucleus moves forward and produces the Argentina flag sign. By using a phaco needle down, so that is one of the things wherein you can go down and you can decompress the front as well as the back compartments very rapidly and very effectively. And also, because of the phaco power or the burst phaco or continuous phaco, it debulks the nucleus as well And because the nucleus are bulky, when you debulk the nucleus goes back and prevents the Argentina flag sign. And this is the parameters I use on a Stellaris machine, which can be used in any machine for that matter, whether it's peristaltic or Venturi system. So you can go here, you can see here how vertically the bevel down is used. This is a 15 degree straight tip. That is the most important thing which you have to use. When you make sure that you enhance the capsule with the trypan blue, use simple HPMC, not high molecular weight like Hyalon GV or Viscoat, and because we don't want anything to occlude the space between the capsule and the phaco needle as well. So the purpose of the study is to do a prospective study preventing Argentina flag sign in capsular excess during capsular excess in white mature cataracts. Number of eyes with white intermittent cataracts are 242 eyes of 242 patients. The punch capsular excess was done with the bevel down 15 degree phaco needle using a high vacuum burst phaco. The parameters which I mentioned earlier. Once the punch was made, the capsular excess was completed with Utterta forceps. The setting was done in Rajanaikar Hospital, Chennai, India. The main thing is to use a bevel down 15 degree or a 0 degree needle, in this case 15 degree needle in this study, and not a Kelman tip or a bent tip. So the number of cataracts with white cataracts type 1 was 190 in this series, and 52 was type 2 in this particular series. Exclusion criteria were traumatic cataracts, complicated cataracts, small pupils, and subluxated cataracts. As I told you earlier, the vacuum was high, about 350 to 400 millimeters. The phaco power was about 40%, burst phaco or the continuous phaco, and it is vertically towards the anterior vitreous and not tangentially. If you do tangentially, then like this case, which occurred in 3 cases out of 242, we do tangentially, and then this is what happens. Argentina flag sign occurs in these patients, because if you go vertically down only, you can punch the capsule as well as debulk the nucleus as well. The puncture axis prevented Argentina flag sign in 239, that is 98%, almost 99% of the eyes out of 242. Puncture axis is a safe and effective technique preventing Argentina flag sign white intumescent cataract. Thank you very much for the patient attention and the wonderful opportunity.
Excellent, Dr. Mohan Rajan. That was a highly innovative method, and I'm sure it's going to help the cataract surgeon for a long time to come.
There is no learning curve in this. That is the main idea of presenting this paper. There is no learning curve, because all of us are doing phaco. What you have to do is just put trypan blue, put simple HPMC, go down and make sure that you punch. That's all. Go down all the way on the phaco machine, like the accelerator in the car, and go down all the way down into the phaco position 3, and then you'll be able to punch it. And almost consistently you'll be able to get a punch on the capsule, which will prevent the Argentine flag. Once you punch that, then you are very sure that the anterior and posterior compartments are decompressed, and the nucleus also, because of the phaco power you're giving, the nucleus also gets debulked and goes back, doesn't come forward.
I have 2 questions. One is,
Yeah.
did you give mannitol for these cases? Because intumescent cases, in our practice, we give mannitol, and that helps doing the rexus much better, and the Argentinian flag sign, because it dehydrates.
That is the third component I was talking about, because there's the positive vitreous pressure also.
Yes.
So give mannitol preoperatively for all these patients, and also do the punch.
And I just wanted to know what are the parameters that you use, and whether you give phaco at the same time. Because is it in panel mode? What was the aspiration flow rate? This is a Stellaris, you said.
Yeah, I'm using a vacuum, Venturi system. I'm using a Venturi system. There's no aspiration flow rate in that. Just to use 400 millimeter vacuum, and just go down straight and punch. Straight away go to phaco 3.
So your vacuum is in panel mode or linear mode?
It's a panel mode.
Panel mode.
Yeah.
Because if you're just giving the vacuum without the phaco, then it may not really create the punches. My concern.
That's right.
So wonderful technique, Dr. Mohan Rajan. I request all our winners of this session not to go away. We'll take a photograph right over there, because whoever wins this session is still a winner. Every one of you who has made this presentation, it's fantastic. So please, Sheetal, Dr. Sri Ganesh, please come up. Dr. Megur, please come up. Dr. Biswas, Dr. Sujata Rajan, Dr. Mohan Rajan, I request Dr. Nagendra Prasad and Dr. G.R. Patel to please come up on the dais so we can have a picture taken with all our presenters. And then I will have Dr. G.R. Patel giving the award to the cataract person, whoever has won the award. Yes? Ah, yes, sir. We'll have to go down and then come back again. Hey, ஆமா. அவன் பண்ண முடியுமா? Without you? Exactly. The best. Otherwise also she could have done it without you.
Yeah.
Yeah, they were all very good papers, excellent presentation. There was some innovation as well. Ultimately, the judges have selected Dr. Mohan Rajan's Panchoraxis. Congratulations, Dr. Rajan.